Hello, my dear students. We are going to discuss the adrenergic blocking agents. And as you know, there are alpha receptors and there are beta receptors. So there could be alpha receptor blocking agents, beta receptor blocking agents, and some agents who could block the alpha as well as the beta receptors. We first start discussing the alpha blockers. Let me remind you, alpha receptor is mainly present in the peripheral blood vessels. And this leads to vasoconstriction. And obviously when you block these alpha receptors, you're going to get vasodilation, and that's going to lead to fall in the blood pressure. The thing doesn't stop here. Whenever there is vasodilation, the heart is going to go into reflex tachycardia, which manifests as palpitation in the patient. The patient is likely to get a throbbing headache due to the vasodilation, flushing of the face, and it could also precipitate angina because it's going to increase the workload on the heart. Because alpha blockers are producing vasodilation, there's going to be increased venous capacitance and there's going to be decreased venous return. And this could manifest into postural hypotension and syncopal attacks. Especially when an alpha blocker is used for the first time, that's the first dose of an alpha blocker, is likely to produce a syncopal attack. And that's called the first dose effect. We need to keep this in mind whenever we discuss the alpha blockers. All the effects based on vasodilation, namely reflex tachycardia, palpitation, throbbing headache, flushing, and precipitation of angina, as well as the first dose effect or the postural hypotension. Let's classify alpha blockers. Let's have a look at the slide. There are non-selective alpha blockers which block alpha-1 as well as alpha-2 receptors, which could be irreversible, that's long-acting. Example is phenoxybenzamine. I would like to remind you of phenoxybenzamine as an example of non-competitive inhibition. The second group is reversible, that's short-acting. Very important short-acting drug is phentolamine, and along with it, it is tolazolin. And coming to the selective, that's alpha-1 selective blockers, you have prazosin, doxazocin, terazosin, and the newer ones, alfizocin and tamsulosin. There is also an alpha-2 selective agent, alpha-2 selective blocker called yohimbine. Alpha blockers contain phenoxybenzamine, which is a long-acting agent, and I told you it produces a non-surmountable antagonism due to the covalent binding. It's useful in the long-term treatment of pheochromocytoma. You need to block the alpha receptors first and then start the beta blockers. Phentolamine is a short-acting agent and is useful by intravenous route of administration, the dose of 5 milligrams for diagnosis of pheochromocytoma, as well as the short-term treatment of pheochromocytoma when you want to deal with an emergency. Tolazolin is useful by oral and parenteral routes in the neonates, especially to treat the pulmonary hypertension. That's the parenteral route of administration for tolazolin. Alpha blockers, which are alpha-1 selective, contain an important drug called prazosin. It's going to lead to vasodilation, is going to dilate the resistance vessels, the capacitance vessels, is going to decrease the preload and afterload on the heart because the resistance vessels are dilated and the capacitance vessels are also dilated. It will decrease the blood pressure. The importance of prazosin is it produces comparatively less reflex tachycardia. When you want to start it orally, always start in a smaller dose, that's 0.5 milligrams 2 times a day. And this is useful for mild to moderate hypertension and acute congestive heart failure. Don't forget the first dose effect with prazosin. First time you give it is likely to block the alpha receptor, and when you try to change your posture, it's going to lead to postural hypotension or a syncopal attack. Terazosin and doxazocin are important when the patient suffers from hypertension as well as the patient has benign prostatic hyperplasia. Doxazocin is a long-acting agent and it acts for 22 hours. Benign prostatic hyperplasia is also important because you got two newer agents. One is alfizocin and the second one is tamsulosin. Tamsulosin is selective at alpha-1A receptors and alpha-1D receptors. Alpha-1A receptor blockade is extremely important because this is going to decrease the smooth muscle tone in the bladder neck, in the bladder base, the prostatic capsule, the prostatic urethra. It's going to decrease the resistance to blood flow and it's going to improve the urine flow. And that's why tamsulosin is useful in a benign prostatic hyperplasia to produce the symptomatic relief in the patient or when the patient has urinary obstruction. Now we revise the adverse effects of beta blockers. Common adverse effects, as I said, are going to be reflex tachycardia, which is less with prazosin, then palpitation, flushing of face, throbbing headache, and postural hypotension. First dose effect with prazosin, and because alpha-1 receptor is going to be blocked, there will be meiosis leading to blurring of vision. Alpha-1 blockade will also lead to nasal congestion and the failure of ejaculation, also due to alpha-1 blockade. Let's have a review. Let's look at this particular slide. All the alpha blockers are summarized on this slide. Prazosin, the first one, is useful in the management of hypertension, in the management of heart failure because it decreases the preload and afterload, and is also useful in the management of pheochromocytoma. Phentolamine is a short-acting agent and is mostly used by intravenous route of administration to treat emergency hypertension and emergency management of pheochromocytoma. Doxazosin and terazosin, as you go down, also start having an effect on the prostate, and it's useful when the patient has hypertension as well as the benign prostatic hyperplasia. Whereas if you come to tamsulosin, it's got less effect as far as the blood vessel, peripheral blood vessels are concerned, and it's more selective at the alpha-1A receptor concerned with the prostate, and that's why tamsulosin is useful in benign prostatic hyperplasia. There could be some drugs which block the alpha receptors, but they also block the beta receptors. These are the combined alpha-beta blockers, includes medroxylol, carvedilol, labetalol, and bucindolol. They are useful in the management of hypertension, heart failure, and pheochromocytoma. Now we come to the beta blockers. Have a nice look at this particular slide. I've exerted on this slide particularly because you should be able to revise all your beta blocker classification with the help of just one single slide. On the left-hand side, you have non-selective beta blockers, and on the right-hand side, you have cardioselective beta blockers. The non-selective ones are also called generation 1 beta blockers, and the cardioselective are also called generation 2 beta blockers. Although we are calling it cardioselective, the real meaning is they are more selective at the beta 1 receptors. Because the beta 1 is in the heart, there's a trend to call them cardioselective beta blockers. Amongst the beta blockers which have been shown on this particular slide, I have made some of the drugs in bold fonts. I'll read the ones which are in the bold fonts. Propranolol, nadolol, timolol, and sotalol on the non-selective side. Atenolol, metoprolol, esmolol, bisoprolol, bitoxolol, celiprolol, and nebivolol on the right hand side. Why did I make it bold? I want you to remember that those drugs which have been written in bold letters are one which are commonly used, are the ones which are most commonly used. So if you want to remember about the beta blockers, at least don't forget these ones which are most commonly used. Amongst all these drugs, you would also find that in front of few beta blockers, I have written an alphabet A. Look here, like in front of propranolol, there is A. Sotalol, there is A. In front of metoprolol and esmolol, I have written A. Please remember the key, this A stands for arrhythmia, and these are the beta blockers which are commonly used for the management of arrhythmias. Apart from this particular slide is also showing you some important things. If you go down on the non-selective side, you're finding 3 blockers which have been shown in a different font. That's pindolol, cartiolol, and penbutolol. The purpose of writing them in a different font is you need to remember these are the beta blockers with intrinsic sympathomimetic activity. That's called ISA, intrinsic sympathomimetic activity. Pindolol, cartiolol, and penbutolol. And finally, if you go down, there are 4 drugs written in a slant, and they're written in italics. That's medroxylol, carvedilol, labetalol, and bucindolol. I am trying to show them separately in italic letters because these are the drugs which are blocking the alpha receptors as well as beta receptors. So they have got a capacity to block both the receptor. What I mean to say is, try to bring this slide in front of your mind and probably you'll be getting all the beta blockers at one place. The combined alpha-beta blocking agents which have been shown in italics here, are also these days called generation 3 beta blockers. They are combined alpha beta blockers and will be useful when you want to block both the receptors, like situations of pheochromocytoma, chronic congestive heart failure, and in the management of hypertension. Once again, to revise, the examples are labetalol, carvedilol, medroxylol, and bucentolol. What is this intrinsic sympathomimetic activity I mentioned? Intrinsic sympathomimetic activity is saying that these drugs are not pure antagonists at beta receptors. They have got a certain partial agonistic activity. And because they have partial agonistic activity, they are going to produce less adverse effects as compared to the other beta blockers. The beta agonist activity can lead to certain amount of bronchodilation, whereas beta blockers are known to produce bronchospasm. There will be less effect on the glucose and lipid metabolism. These drugs include S-butylol, pindolol, penbutylol, cartiolol, carvedilol, and labetalol. This carvedilol is important because it has been shown to decrease the peroxidation. It has been shown to decrease the wall thickening, and this is why carvedilol is preferred in patients with congestive heart failure. Labetalol is useful to treat the pregnancy-induced hypertension, and it's also useful in the hypertensive crisis. Let me mention about a special drug, that's Timolol maleate. There's a beta blocker, and this could be useful for chronic management of glaucoma. It works by decreasing the aqueous humor production, and there's no change in the size of pupil. It's available as eye drops. In addition to this, you have a cardioselective beta blocker, betaxolol, a longest acting beta blocker, levobunolol, cartiolol, levobetaxolol, and metoprolol. All of them could be useful in the management of glaucoma. Now we go to discuss the toxicity of beta blockers, remembering propranolol as the prototype. Remember, it's going to block the beta receptors, and if it's non-selective, it's going to block beta 1 as well as beta 2 receptors. So when you start blocking the beta 2 receptors, it's going to lead to bronchospasm, and it's going to precipitate conditions like bronchial asthma, or the patients who suffer from chronic obstructive pulmonary diseases are going to get bronchospasm. The second important beta 2 receptor is present in the liver, and we are going to block this beta 2 receptor. What's going to happen is, in response to hypoglycemia, the liver is not going to bring in the glucose to the systemic circulation. So what's going to happen is, this patient is not going to respond to hypoglycemia, which is called hypoglycemia unresponsiveness. And this will be a very important condition of diabetes mellitus, in which these drugs could prove dangerous. The patient would go into hypoglycemia, and this hypoglycemia would not get corrected. Beta blockers, most importantly, decrease the lipolysis, increase the VLDL, and decrease the HDL, which are not good signs for a patient with hypercholesterolemia. The long-term administration of beta blockers leads to decreased contractility of the heart and can make the heart more susceptible to ventricular dilation, congestive heart failure due to the decreased contractility. Next important thing to remember is, it's an antagonist. So if you're giving it for a long period of time, it's going to lead to the upregulation of receptors, leading to the supersensitivity. So if you stop these drugs abruptly, the abrupt withdrawal could lead to inguinal attacks, arrhythmias, myocardial infarction, and hypertension. Upregulation being the important cause behind this. The prolonged use of beta blockers also leads to fatigue, mental depression, and sexual dysfunction. Let's know some important drug interactions of beta blockers. If you give them with the hepatic microsomal enzyme system inhibitors like cimetidine, fluoxetine, paroxetine, or ritonavir, these drugs are going to inhibit the breakdown of propranolol or the beta blockers, and there's going to be increased toxicity of the beta blockers. Whereas, if you use them with inducers like rifampin, barbiturates, and phenytoin, is going to induce the breakdown of beta blockers. They'll be metabolized fast, and the effect of the beta blocker is going to be less. Beta blockers as anti-arrhythmic agents is a very important issue. They are class 2 anti-arrhythmic agents, namely propranolol, metoprolol, sotalol, and esmolol are the anti-arrhythmic drugs, and they are preferred in the management of supraventricular tachycardias and digitalis-induced tachyarrhythmias. We need to remember an important thing about esmolol, which is an ultra short acting agent. It acts very fast and is useful for critical arrhythmias like acute arrhythmias in critically ill patients, intraoperative and postoperative arrhythmias, post-myocardial infarction arrhythmias, and sudden death after AMI, as well as the arrhythmias associated with cardiac catheterization. Finally, we come to discuss the uses of beta blockers, keeping in mind propranolol as the prototype drug. Firstly, it's useful in hypertension. We need to know the three mechanisms by which beta blockers decrease the blood pressure. Number one, they block the beta 1 receptors in the heart and decrease the cardiac output. Number two, they block the beta 1 receptors in the juxtaglomerular cells of the kidneys, leading to decrease in the renin activity. And they also act on the central nervous system to decrease the central sympathetic outflow. Next important use is chronic prophylaxis of angina, in which the beta blockers increase the exercise tolerance, they decrease the oxygen consumption, and they decrease the rate of the heart. Next, you can use beta blockers along with alpha blockers. Rather, first give alpha blockers, produce enough alpha blocker, and then start a beta blocker for a patient with pheochromocytoma. So also, you can prevent the myocardial infarction on chronic basis by the use of beta blockers. It's also proven that they are useful in cases of acute MI to limit the infarct size in this patient. They are especially useful for supraventricular tachycardias, including atrial fibrillation and flutter, AV nodal re-entrant tachycardias, and catecholamine-induced arrhythmias, as well as the digitalis-induced tachyarrhythmias. This slide is showing you all the effects of beta blockers, which are mostly concerned with the cardiovascular system. Now we go to the other uses of beta blockers, which are equally important, and it contains thyrotoxicosis. For short-term adjunctive therapy, beta blockers are extremely useful because they decrease the manifestations of anxiety associated with thyrotoxicosis. They are going to control the blood pressure, they are going to control the heart rate, and they are going to decrease the anxiety. Propranolol has got some additional value because it can also affect the peripheral conversion of T3 into T4. Sympathetic effects and arrhythmias in thyrotoxicosis are going to be controlled by the beta blockers. So also, because they are decreasing the manifestations of anxiety, they are useful in anxiety states. Just to give an example, it could be useful to prevent the stage fright. But more important is, all the anxiety associated disorders, you could use beta blockers. They are also useful to treat the alcohol withdrawal symptoms and the various drug withdrawal states. They are useful to treat essential tremor and familial tremor. They are useful to prevent the tetralogy of phallocyanotic spells. They are useful in the chronic prophylaxis of migraine due to the blockade of the catecholamine-induced vasodilation in the cerebral vasculature, and they are useful in the symptomatic management of hypertrophic subaortic stenosis. I especially want you to remember esmolol as an ultra-short acting agent which acts for 8 to 10 minutes. It's the half-life of esmolol and is used intravenously. Please don't forget the arrhythmias associated with surgery, the arrhythmias associated with various diagnostic procedures. Second important thing to remember is nadolol, which is the longest acting beta blocker, and its half-life is 24 hours. There's a special use for beta blockers like propranolol and nadolol. They are used to decrease the portal venous pressure and to prevent bleeding and death in patients with liver cirrhosis and esophageal varices. So that was a review, that was a summary of alpha blockers as well as beta blockers. I hope this presentation will be extremely useful to you. Thank you very much.